morning, everyone. My name is Jim McCracken. I'm the Division Director of Child and Adolescent Psychiatry, and it's my distinct pleasure to introduce the 2022 Dennis Cantwell Memorial Lectureship. This is a lectureship that was founded in 1999 to honor the legacy of Dr. Dennis Cantwell, who had been a faculty member at UCLA since 1972. I was the longest serving training director in child psychiatry and represents a seminal figure in the field of child psychiatry. What Denny touched turned to gold in terms of his research and areas of expertise, moving the field greatly forward in areas of classification of child mental disorders, appreciating the prevalence of depression in youth, delineating multimodal treatment for ADHD, and on, authoring over 200 scientific papers and co-authoring and editing 5 books, a leading figure in child mental health. This lectureship is to honor Dr. Cantwell's legacy and to continue his mission of enhancing care for children with mental disorders and highlighting the scientific basis of child psychiatry. It's a delight that this year we've been able to invite Dr. Ryan Herringa from the frozen tundra of Wisconsin to join us here and to introduce our distinguished speaker, Dr. Silvers.
Thank you. Yeah, March is a good time of year to have somebody do this flight. So it is my pleasure to introduce Dr. Ryan Herringa, who is the University of Wisconsin Health Professor of Child and Adolescent Psychiatry, as well as the Director of the Division of Child and Adolescent Psychiatry at the University of Wisconsin-Madison. I first had the pleasure of meeting Dr. Herringa about 6 years ago at APA, where we discovered shared interests in the developmental neurobiology of observational fear learning. And I've really just been a huge fan ever since. So it's a great pleasure to get to introduce you today. As you'll hear, Dr. Herringa is a physician scientist whose work seeks to uncover how stress alters pediatric neurodevelopment and behavior, as well as the implications for stress exposure in mental illness in youth. There's a lot to love about his program of research, but I'll mention just 3 things that stand out to me in particular. The first is that he takes a truly developmental approach to his work, considering both developmental trajectories and how they unfold over time, as well as the developmental timing of stress exposure and what the implications may be for these aspects of development on both mechanisms and treatment. The second is that he is unusually comfortable and savvy with working at multiple levels of analysis and with multiple methods. So this is really striking when you hear him speak, his comfort with talking about affective neuroscience, as well as using it to inform treatment. And then the final thing that I'll note, which I think actually dovetails off of that last point, is that his work is truly translational. Integrating sort of theories and data from, especially theories from non-human animal models, to considering experimental work in patient populations to informing treatment. Dr. Herringa's research is supported by an impressive extramural funding portfolio, and he's received numerous honors, including being an associate member at ACNP, a distinguished fellow in the American Academy of Child and Adolescent Psychiatry. So with that, please join me in welcoming Dr. Herringa.
Jen, thank you so much. Hopefully everyone can hear me okay. That was a very tall introduction to live up to, so hopefully I can do that justice, as is very, very kind of you. Thanks also to Jim for the invitation to be here. It's really an honor to be presenting as part of Dr. Cantwell's legacy. So that's, when I talk about big shoes to fill, maybe we can all do a bit of that together. So I'm really excited to be here. For those of you in person or online. It's great to see you. I'm going to be talking to you today about some of the work that we've been doing at Madison in the treatment and neurodevelopment in pediatric PTSD, and Jen alluded to a bit of that. And to keep this or make it more accessible for a wider audience, I'll be covering some content both on assessment and treatment of trauma in youth, as well as what we're learning about the neurobiology behind trauma exposure in youth and risk and resilience for mental illness, particularly PTSD. Jen mentioned some of my funding sources. I don't have any potential conflicts of interest to disclose, and very grateful to our funders for making this work possible. So as I mentioned, we'll do a mix today of some epidemiology, as well as assessment treatment for PTSD and trauma more generally in youth. And then I'll go over some of our more recent neuroimaging data, looking at neurodevelopment and trajectories in youth with PTSD in particular. Before we do dig into those, I want to acknowledge the Wisconsin First Nations. So where I work and where I live is actually on Ho-Chunk ancestral lands. And so I think it's increasingly important now more than ever to recognize the privileges we have and what was taken from many Indigenous communities in the past, and that we're acknowledging those communities in the work that we do. And in preparation for coming here, I had to do some research and learning about the Indigenous nations of Southern California, and learned that LA and UCLA is on ancestral lands of the Keech Nation. And so also acknowledging them as well as other nations in the area. So before I dig into some of the content on assessment, treatment of trauma, on the neurobiology, I wanted to say just a little bit about how I got into this line of work. Working with traumatized youth and families, I would be the first to admit, is not for everyone. It's a taxing area to be in. As we'll talk about, there can be vicarious traumatization, burnout, which certainly goes for any area of mental health work that we're doing now. And thanks to all those mental health providers, both here and watching online, for all you do. But I think I realized early on, probably in medical school, that mental health was something I really wanted to be involved in. I was fascinated by the brain from a scientific perspective, and how it was that individuals were developing mental illness or resilience, for that matter. I also became acutely aware, both through the privilege of my childhood and not growing up traumatized, but also in working with so many families and children who have been through trauma, that this was an incredibly potent risk factor for developing mental illness. And we'll talk about some of those statistics in a bit. And I came at this initially, when I was at UW-Madison, with the mindset of, well, if I can help to understand how trauma and stress more generally is leading to mental illness or resilience, then perhaps we can begin to capitalize on the neuroplasticity, particularly in the developing brain, to shift it in a way that allows that child to thrive. And the domino effects obviously are huge well into adulthood. Now, I went to the University of Pittsburgh for residency in the Child Psychiatry Fellowship. And to that point, I hadn't really worked in depth with trauma-exposed youth and families. And so part of me was still like, well, I don't know if I'm going to be able to do this sustainably. Is it simply going to be too much for me to carry? And I had the fortune of working with Judy Cohen, Tony Manarino at the Center for Traumatic Stress for Children and Adolescents for a full year, and learned trauma-focused CBT. And it was during that time that I realized the privilege that I had in working with these families. And I admittedly went into it probably initially with some savior mentality. I'm going to try to fix this family and help them to heal and all this stuff. And I quickly learned a couple of things. One, I could do this kind of work. For whatever reason, I was able to not completely take it as mine or become traumatized through working with these families. But I also realized that these children and families are incredibly resilient, and they have this capacity to be present and in the moment, despite the many horrible things that may have happened to them. They also quickly taught me that I didn't have all the answers. And so it was a very humbling experience too. And I learned that I need to really walk beside them, walk with them, and try to be a help or a guide in their journey. It's ultimately they who have the answers and know what's going to work for them to recover. So I'm incredibly grateful for all the families, patients I've had the opportunity to work with, and who have also volunteered for the studies that I'll later tell you about. So let's pivot a bit to some of the statistics on trauma. We are at one of the national centers for the study and treatment of trauma and PTSD in youth and adults. So some of you may be familiar with these statistics, but I think it's worth reiterating. It's extremely common. So nearly 2 out of 3 youth experiences a potentially traumatic event by age 18. If you look specifically at childhood abuse, so physical or sexual abuse, which is one of the most potent types of trauma in terms of risk for mental illness, there the numbers are still staggering. 1 in 4 to 1 in 5 children have been abused in one of those forms by age of 18. So we have this continuing epidemic, if you will, probably more like a pandemic of trauma that's ongoing. And of course, this has been certainly, well, we don't know. This may be worsened by the experience of the pandemic these past couple of years. That could be an interesting discussion point. I haven't seen a lot of data on that yet. The other thing I want to acknowledge is that trauma and adversity more generally is not distributed equally. And for groups that have been historically marginalized, they are also much more likely to experience adverse childhood events. And that's can be shown or seen here in this national map. So what you're looking at is the percentage of individuals in each of these geographic areas in the United States with no ACEs, no adverse childhood experiences. And the blue shaded numbers are groups that are significantly lower than the average, or in this case, the white population. And those groups are more likely to have had at least one adverse childhood experience. And as you might guess, these groups are pretty consistently Hispanic and Black communities, as well as others. So the degree of trauma, the degree of adversity is certainly not distributed evenly. I also think it's reflected or can be reflected in ACE's pyramid. And I really like this depiction from the RISE Center about how marginalization, historical trauma really makes for a very different kind of ACE pyramid. And the typical ACE pyramid that we think of is on the left, and starting with at its foundation or its base, the adverse childhood experience itself. But in the case of marginalization and traumatization of an entire community of people, we're really looking at something more on the right, where there are these wider foundational, very deep layers of trauma that's been embodied across generations. And there's emerging evidence that that's even happening epigenetically, that those changes are being passed from parents to offspring. They may also be modeled behaviorally. And these are things that Jen and I are both trying to study in the laboratory environment. And of course, the social context that's been a result of discrimination, marginalization, really remove some of the supports that children, families might otherwise have to be able not only to thrive, but to recover from trauma when it happens. So what do we know about childhood trauma and risk for mental illness? I mentioned earlier just how potent of a risk factor this is. And if you look generally at childhood adversity, it accounts for almost half of the risk for childhood onset psychiatric disorders. That number still just boggles my mind. And even for adult onset disorders, accounts for to a third of the risk. Sorry, let me know if I'm cutting out a little bit. But it not only accounts for a heavy or large amount of risk for psychiatric disorders, but is also associated with a much more pernicious outcome and poor prognosis. So children or adults for that matter who've been through significant adversity, particularly abuse, tend to have earlier onset of mental illness, tends to be more severe with greater comorbidity and less responsive to treatment. So there's certainly a lot we need to understand about what's happening in terms of neurodevelopment and biology to help these individuals. Now, what about specific diagnoses, you may be wondering? So of trauma-exposed youth, I've listed some of the major categories of diagnoses here for mental illnesses. Depression is certainly common, PTSD, of course. But anywhere from a quarter to a third of youth who have been through trauma will experience a depressive PTSD or other type of disorder. Notably, suicide attempt and self-harm are also very significant here, and that's something we'll come back to in just a little bit. So I was just talking a little bit about the incidence of certain specific diagnoses in youth who have been exposed to trauma. The flip side of that is actually that most youth are quite resilient. And if a quarter to a third are developing a mental illness after trauma, that means the rest of youth aren't. Of course, we'll go into why that may be, what are some of the risk and protective factors. It certainly does make a difference depending on certain variables that we'll talk about in just a sec. All right, now I understand you all aren't seeing this, but this next slide is about PTSD specifically in kids. So we talked about a broader variety of diagnoses earlier, but what about PTSD? So lifetime prevalence for PTSD in youth is about 5%. That's slightly higher in adults, where it's at 7%. As in adults, that varies widely by the type of trauma. So whereas 7% of youth may develop PTSD following a motor vehicle accident, that number rises to 30–40% in cases of interpersonal violence. Finally, the last piece I've mentioned is that symptoms may be delayed in terms of onset for youth with who develop PTSD. That I've seen better data for adults. It's certainly not clear what percentage of kids will show a delayed onset of PTSD, but I've certainly seen that in clinical practice as well. We're just talking a bit about the epidemiology of PTSD specifically. If you're curious about some of the stats, I encourage you to look at the NIMH's website for mental health statistics. You can see more on that. A couple of things I would just note here. It's far more prevalent in females as compared to males. It's typical with adult PTSD as well. You also notice the developmental pattern where PTSD is increasing markedly in incidence by late adolescence. What we don't know at this point is whether that's due to increasing vulnerability in adolescence as a function of neurodevelopment, or is it because of increasing cumulative trauma and stress exposure, both, or other factors. So I'm going to speed up just or keep up the ramp up the pace just a little bit to keep us on track here. Some of the risk factors for PTSD we've talked about, certainly being female is a big one, but prior trauma load or psychiatric disorders are risks as well. We talked about some of the trauma characteristics. Parental acute stress is an important factor here as well. Something that certainly needs further study, but is likely to be particularly important. And then finally, post-trauma, whether there are intrusive ruminations. In other words, is that trauma being replayed over and over? Is there social support, whether from parents, community, school, elsewhere? All of these are really important factors for whether a child is going to develop PTSD. So what about assessing youth with trauma and PTSD? Again, you're at one of the centers for doing this. So I'm just going to highlight, I think, a couple of important points that I think are really salient in my clinical experience. Certainly establishing rapport is an important first step and not immediately going into asking about the trauma. By the same token, it's important not to be afraid for us as clinicians to be able to talk about the trauma, or as researchers for that matter. Using a multi-informant approach in a clinical setting, safety first, making sure that abuse and trauma aren't ongoing. If they are, that's really taking the priority at that point, rather than trying to do an exposure-based therapy, which could actually worsen outcomes if there's ongoing trauma. There are a number of standardized instruments for assessing PTSD in children and adolescents. One which was developed here by Dr. Pinus and colleagues, the UCLA PTSD Reaction Index. I list some others there. And then finally, the self-care. So watching for vicarious traumatization is particularly important in this line of work. Now, comorbidity is also something to be on the lookout for, and nearly actually 2/3 of kids with PTSD will have some comorbid mental illness. ADHD, as you can see, is the most common one, and is usually preceding PTSD in many cases. It's possible also that that may be an additional risk factor and share some neural circuitry that's underlying risk for ADHD as well as trauma. Certainly the other anxiety disorders, mood disorders are very, very common to see with alongside of PTSD. I mentioned suicide earlier as another big risk following trauma outcomes in that previous slide. But here is specifically with relation to PTSD. This is one of the most stunning, I think, analyses I've seen, that PTSD carries the highest risk of all mental illnesses for first suicide attempt in adolescents as well as young adults. And highlighted there is the hazard ratio for suicide, first suicide attempt in youth with PTSD with a hazard ratio of 15. The next closest is a hazard ratio of 7 to 8, nearly half the risk, and that's for depressive disorder. So it's really important that we keep an eye out for this and be very vigilant in assessing kids with trauma and PTSD for suicidality. Now, what I don't know is whether this is also a function of trauma exposure itself. And so if you took some of these other illnesses and combine them with trauma exposure or childhood abuse, as we talked about earlier, whether that risk would be similar or different, I think remains unknown. So let's go into treatment for a few minutes here. Oftentimes I get asked by pediatricians, primary care doctors, educators, parents, can we prevent PTSD? And the short answer is not really. We don't have any really strong evidence-based or therapies that can do this as of yet. There are some small trials for pharmacological agents suggesting that beta antagonists, morphine may be helpful. Morphine, particularly in the setting, in a medical setting where acute pain control is needed, can be really helpful for preventing some of the sequelae. There are programs called the Psychological First Aid and Skills for Psychological Recovery that have shown to be helpful in preventing not just PTSD, but other adverse mental health outcomes following trauma and stress in youth. These are available on the NCTSM website, the National Child Traumatic Stress Network. So I would encourage those of you interested to check those out. What I would note is it does not involve debriefing, which was something that has been tried historically. So this does not involve a recounting of the trauma or stressful events that happened. Rather, really bringing about community supports, social supports, and that child's own individual coping skills to help them recover. Now, what about specific treatments for PTSD when it's developed? So trauma-focused psychotherapy is really where it's at. You all do a lot of that here at UCLA. The effect sizes are modest. So the moderate effect sizes in the short term become somewhat smaller in the longer term. What's nice is that these therapies also exert reductions in depressive and anxiety symptoms. It's not just the PTSD itself that seems to improve with trauma-focused therapy. I've listed a number of evidence-based psychotherapies below trauma-focused cognitive behavioral therapy, or CBT, as by far the largest evidence-based. I would note that all of these therapies have some evidence behind them, and all of them target largely similar mechanisms in that exposure is a big piece of it, as well as cognitive reframing. And we'll come back to that towards the end of the talk, because I think we really are limited in many ways by the options that we have to treat trauma and PTSD in youth, and need to be creative in targeting either the biology or different psychological mechanisms, or both, in trying to allow youth a greater degree of treatment options. Pharmacotherapy. Well, briefly, there is none for pediatric PTSD at any rate, at least nothing that's FDA approved, nothing that has a strong evidence base for it. And this is in contrast to adults, where SSRIs at least are one first-line treatment that shows benefit. But the few and admittedly small studies that have been conducted in pediatric PTSD haven't shown any improvement beyond doing psychotherapy, for example. Benzodiazepines, similar to adults, should be avoided in pediatric PTSD, may actually worsen their condition and be counteractive to the therapeutic process, the psychotherapy. And we can get into possible reasons for that later. There are some case reports that suggest adrenergic blockade can be helpful. Certainly in my practice, I've seen youth benefit from clonidine, guanfacine, things that reduce sympathetic outflow in terms of helping with hyperarousal and sometimes insomnia and nightmares as well. But again, those are anecdotal experiences, and we certainly need more research to understand what may be helpful. Treating comorbidities is definitely important, and we have evidence-based pharmacotherapy for these conditions with depressive and anxiety disorders, making sure ADHD is well treated. If it's not, it makes trauma-focused therapy really difficult to do, and difficult for the family to make gains. And again, we're hinting at insomnia on the last slide. That's an important area to consider as well. Okay, so let's pivot now to, I'd like to tell you about some of the more recent findings we've been demonstrating and publishing on in terms of neurodevelopment in pediatric PTSD. And over the last couple of years, we are increasingly finding in our samples, as well as others, that there are age-related or developmental abnormalities that appear to be characteristic of PTSD and of trauma exposure, and that differences in these neurodevelopmental pathways may play an important role in resilience or recovery from PTSD, as well as making a more pernicious course of mental illness in the long run. So we'll dig into that a little bit. But what we've been finding, and this is some cross-sectional data I'm showing you here, is that there are age-related changes in emotion regulatory circuits in particular in youth with PTSD. And this work was done by Justin Russell, who was a postdoc and currently a scientist in my lab, finding that white matter integrity, so here is measured by a fractional anisotropy, in every major white matter tract appears to be decreasing with age in youth with PTSD, whereas we would expect to see increases with age in typically developing youth, which we do in fact here see. Those are the lines in black. We've also published data showing that there are functional developmental patterns. On the top showing a cross-sectional study where typically developing youth show decreased amygdala activation with age, as you would expect, and Jen has published similar findings as well in larger samples for that matter. Whereas in youth with trauma and PTSD, shown in red, they show increasing amygdala activation with age. Similar to this, in terms of functional connectivity between the amygdala and the ventromedial prefrontal cortex, we've looked longitudinally over the course of a year and found that whereas youth who are typically developing show increased connectivity in this circuit over that time, youth with PTSD in red show decreased connectivity over the course of a year. Now, what you may also be picking up on is that in all of these instances, if you look at either the younger ages or the baseline time point, it's almost as if those youth with PTSD, that is, show a more mature pattern, if you will. In other words, they look like the older, typically developing youth. However, that adaptation, if you will, also seems to be lost with age or with time, and we don't know exactly which. So why might that be? Well, a couple of the models that we are looking at are the stress acceleration as well as adaptation and latent vulnerability models. And we may be seeing really combined effects of multiple processes that are ongoing. So the stress acceleration hypothesis would say that in the face of significant stress or trauma early on, that there are certain neuro or biological systems that are going to advance, that are going to mature earlier in order to allow that child to cope, to survive in a potentially unpredictable and very dangerous environment. That kind of data, I think, has been best shown for pubertal development at this point. It's really not entirely clear how well that applies to neurodevelopment, and that's something that we're trying to dig into. I'll show you some data on that shortly. Another aspect of this, though, is that there may also just be general adaptational changes in the brain that really are not a function of maturation or maturational pace, but rather bringing different neural systems online or altering different neural system to allow an individual to try to cope with a difficult environment. Now, those adaptations may also, in turn, contribute risk for vulnerability down the road, what Eamon McCrory has called the latent vulnerability hypothesis. So in that setting and in the short term, they're adaptive. Say a system that increases vigilance, right, detection of threat, that could become problematic down the road if one's always operating under that framework, and perhaps even moving from a dangerous to a safer environment. It now becomes maladaptive to be on hypervigilant, on lookout for threat in every case. So I want to tell you about a couple of recent studies that we've been working on, trying to estimate brain age or brain maturation index in youth with trauma, as well as psychopathology, some of which have PTSD. And what we have done, and this is work that's been led by Taylor Kading, who's a former graduate student in the lab, now postdoc with Dylan G, is to use machine learning on typically developing youth and inputting either structural or functional brain markers and creating a normative model of development where we can then use that to see how well it maps onto a youth's chronological age. We can then apply that model to youth in a clinical population, say with trauma exposure or with mental illness. And we can then ask how well does the model that we just used, derived from typically developing youth, predict this child's brain age? And what is the gap? What is the deviation between that expected brain age or the predicted brain age and their actual chronological age? And so that's called the brain age gap. So in the first study, Taylor looked at a cohort of almost 250 girls who we categorized as exposed to abuse or not, and then resilient or vulnerable, depending on whether they developed an internalizing disorder. And Taylor looked at 3 different major circuits in the brain, and this is all gray matter volume, if I hadn't pointed that out earlier. So he looked at whole brain gray matter volume, but then gray matter volume specifically within emotion and language circuitry. Language circuitry served, our intention was to serve as a negative control. We didn't expect any advance or delay specifically in that circuitry in relation to trauma exposure. So what did Taylor find? He found, intriguingly, that emotion circuit maturity specifically was delayed in girls who had been exposed to abuse. That's shown in panel B. And surprisingly to us, it was both the resilient and susceptible girls who showed delayed brain age, specifically in the emotion circuit. So it didn't seem to matter whether they were resilient or vulnerable. In contrast, there were no differences in brain age or brain maturation in the brain as a whole amongst these three groups, nor in the language circuit, as we predicted. We also found that the more delayed the maturation was in emotion circuitry, the greater the hyperarousal symptoms that were present, which really suggests to us that this may be an adaptive mechanism, that there may be delayed maturation in the circuit that's allowing for perhaps a greater ability to detect threat or threat generalization, again, in an environment that's likely been unpredictable and unsafe. Now, while we saw that general effect on brain maturation independent of resilience or vulnerability, what we did find is that the pattern of features, of neural features contributing to brain age estimates differed markedly in the two groups, in resilient and vulnerable girls. So in resilient girls, we found, for example, that the executive network contributed to increased maturation, whereas the threat or salience network, including the insula, contributed to decreased maturation. So this suggested to us that there's actually perhaps some compensatory response in executive circuits that may allow resilient girls to be in fact resilient. When we looked at girls in the vulnerable group, we found essentially the opposite. We failed to see this increased maturation in the executive network circuit, the frontoparietal circuit, and in contrast to decreased maturation related to threat circuitry or salient circuitry in the resilient girls, it contributed to increased maturation in the vulnerable group. And additionally, we found some notable differences in the hippocampus as contributing to decreased maturity. That I think is particularly interesting as well. The hippocampus obviously has an important role in learning and memory, but it's also really critical for contextualization and limiting of threat responses based on the situation, based on the context that one is in. So there's some very interesting potential mechanisms that could be at play that are contributing to some of the vulnerability we're seeing. Okay, so I'm mindful of our time. I will go through these next couple of slides a little bit more quickly. Suffice it to say, this is now looking at functional connectivity, resting state connectivity between the amygdala and the prefrontal cortex as a whole, with a similar question. What are the brain age differences that may be underlying both trauma exposure as well as risk for psychopathology? This is unpublished work that is in preparation right now, also done by or led by Taylor in a larger cohort now, the Philadelphia neurodevelopmental cohort. And when we looked at resting state functional connectivity between the amygdala and prefrontal cortex, here we found, again, that there was delayed maturation in this very, very critical emotion regulatory circuit. Interestingly, though, it was in the vulnerable group only. In this case, youth who had been exposed to violence and developed externalizing disorders or significant levels of symptoms. We further found that in youth who were trauma exposed, that delayed maturation in this circuit, specifically basolateral amygdala prefrontal circuit, was associated with increasing symptoms. So somewhat in contrast to the structural brain findings, which appeared to have some non-specificity in relation to trauma exposure and brain age, here some of these brain age delays or maturational delays perhaps are specific to vulnerable populations of youth. So there's still a lot to be really teased apart there, and a lot we don't know. But in all, just to summarize some of the brain age analyses that we've done, there's certainly convincing evidence, I think, at this point, that trauma appears to delay maturation in certain emotion circuits and perhaps other circuits in the brain. What exactly that means in terms of risk of resilience for psychopathology, I think remains to be seen, as well as the specific circuits that are involved and how they're influencing the maturational prediction. But some of the early evidence at least suggests that resilience may be marked by either a retention or early maturation of executive control networks that may allow some of these compensatory responses. What about PTSD over time, and what about the neurobiology of treatment and recovery? I'll say just a couple of things here to highlight the neuroplasticity that I think we can really harness in youth in the developing population. And we've published some data. This is from Sarah Hain, who's now a scientist in my lab, showing that youth who naturalistically recover from PTSD over the course of a year actually show expansion of the prefrontal cortex, so the frontal pole, the ventromedial prefrontal cortex, that's associated with a reduction in symptoms over that time. Amy Garrett and her colleagues have also published data in a trial of trauma-focused CBT showing that areas, again, of the executive control network, here the dorsal and ventrolateral prefrontal cortex, show volume increases over the course of trauma-focused CBT. Consider this is only a 12 to 16 week treatment we're talking about. So those are, I think, are pretty substantial changes to see in that short amount of time. But what these studies highlight to me again is the critical, likely important role, I should say, of this executive control network and its ability to be enhanced or mature early or come online in a way that allows for more adaptive emotional responding. So I will briefly highlight the takeaways here. We've talked about how trauma-focused psychotherapy is really an effective and the first-line treatment for pediatric PTSD. Unfortunately, no pharmacotherapies, at least evidence-based, exist at this point, so we certainly need to have more work to do there. And then finally, as I highlighted, recovery from PTSD and perhaps even resilience from developing PTSD in youth may depend on the integrity and restoration of executive function circuits. So I put in an illusion, a brief pitch for finding newer and novel treatments that presumably could target this circuitry. And I want to end just by showing you one such modality that we're exploring that I'm hoping will be much more palatable for youth than coming in and talking with a therapist about all the bad things that happen. We're trying something called virtual reality biofeedback, and this is specifically using breathing to facilitate one's movement through a virtual reality environment. And I'll play you a clip here shortly. And our hope is actually that this can target the amygdala prefrontal circuit that we're talking about, which is heavily involved in physiological awareness and regulation and emotion regulation. So here we go. Let's hope this plays. So that's a bit of a preview, and that's an early version of Deep, and it's an incredible team we've been working with We're also just beginning to pilot this with youth in our juvenile detention center in Dane County, and really enlisting their help as collaborators, because we want to get their input and see what works and what doesn't with this platform. So here are some resources for you at the end if you're curious, and I will stop there. Hopefully we've got a few minutes for questions. Thank you, everybody.
Well, thank you very much, Ryan. That was fantastic, and I appreciate your grace under pressure as well. A highly developed skill. I have to pull myself out of the trance that I went into with that
Very
last piece.
soothing.
That was really remarkable and fascinating. Such a remarkable kind of comprehensive review. I'll maybe start off with just one or two questions to get things going. And please feel free to submit your questions online for those of you who were connected. Can you speculate a little bit perhaps about that relatively dramatic adolescent increase in prevalence in PTSD? And what may underlie that?
Yeah, it's a great question. I think that it is due in part to an increased vulnerability in the amygdala prefrontal circuit, and hippocampal prefrontal as well, but in prefrontal connections to limbic regions during adolescence. And Marty Teicher, Susan Anderson have published some data in the past too, showing that there may be increased susceptibility in this circuit, both in animal models as well as in humans, that's hormone dependent, where pubertal hormones in particular may make these circuits more sensitive to the effects of glucocorticoids. This is stress hormone exposure. So I think that's probably one mechanism that's at play. And perhaps there are some inflammatory mechanisms at that point too. I've not seen really good data on that in humans yet. But I do think when you combine that with the dramatic increase in trauma exposure and adversity in adolescence, that's at least the lowest hanging fruit of what's likely to be going on. I think those are key players.
Thank you. Let me pick up an online question. Can you please tell us whether you found any different lateralized differences in right versus left amygdala response in susceptible versus resilient youth?
This is with relation to brain age or cross-sectional data. So what we found, the short answer is it's been very mixed in terms of findings that we've seen. So I think if you lower the statistical threshold, we tend to see similar effects bilaterally. The amygdala activation difference I showed folks was in the right hemisphere, but then some of the connectivity differences in development are left amygdala to prefrontal cortex. So it's not entirely clear to me at this point if there's a consistent lateralization effect and what that may in turn mean for resilience and vulnerability patterns. It's a great question. I wish we need some further work, I think, to answer that. Jen, do you have something to add to that?
Yes.
Oh.
I wasn't sure if you wanted to get people from online. That was an awesome talk. I really enjoyed it. And I was thinking at the end about, you pointed to at the beginning, what are some of the potential resilience factors? And one of the things you noted is social support. Later on, you presented really fantastic evidence pointing towards executive control circuitry, which I loved. And I'm wondering your thoughts on whether there might be intervention or treatment opportunities for combining those two factors or leveraging them. Thinking about the kinds of environments that youth are growing up in who are particularly susceptible to being exposed to trauma, might there be opportunities not only to intervene with them to improve executive function skills and associated circuitry, but also, for example, with caregivers?
Yeah, I love that question, Jen, and absolutely. I think that's the parents are critical in this. even for adolescents, for teenagers, it's easy to underestimate how important caregivers still are at that age. So I think you're absolutely right. They're a critical point of intervention that can really help that child or help that teen to be able to recover, or even to be able to sustain, the effects of a trauma or adversity. One of the things we're studying, as you probably know in our lab, is how fear extinction learning may be transmitted from one generation to the next, and in particular from a caregiver to a child. And some of our early data, our pilot data, suggested actually that caregivers, in cases where youth have PTSD, caregivers may be transmitting heightened threat signals during their own extinction learning to the child. So they're modeling essentially anxiety and threat responses. So I think if we can help parents, caregivers more broadly, to regulate their own emotions, their own responses in a way that's appropriate for the context, right? We don't want them sort of just blindly modeling safety when there's actually a lot of danger out. But if we can help them to modulate their own emotional experiences and then model that for their children, I think that there's a lot of potential there. We're also looking at trialing some other types of therapies as well, that more broadly have parallel tracks, if you will, for youth with PTSD as well as a supportive caregiver, so that ideally they're learning the same skill set as they go through. But I think, as you're alluding to, that could be applied at a much larger, broader level in terms of prevention and wellness, and doesn't have to be simply done after child has developed a mental illness. It's great point.
Well, unfortunately, we're out of time. I want to thank you for a wonderful talk, and Dr. Cantwell, been very, very pleased. So thank you so much for coming and for sharing your very important work.
That means a lot, Jim. Thank you so much. It's a pleasure.
Thank you all.